Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. J. Calvert. I'm here in a suit, which is unusual, because we are on our way to the Los Angeles Society for Plastic Surgeons meeting with my amazing co-host, Dr. Millicent Rovelo. How are you?
I'm doing excellent. How are you?
You are also dressed appropriately for the meeting.
I am. I'm all dressed up. We're looking very spiffy today because we are going to this meeting. It's the LA Society of Plastic Surgeons. We have quarterly meetings where we talk about different topics. And today, or tonight's topic, is actually going to be sort of a mini focus of today's podcast.
Yes, we're going to talk about upper endoscopic facelift, which is where we're doing the upper face through small incisions with the assistance of an endoscope.
Correct. So that's the topic for the Los Angeles Society of Plastic Surgeons. And the topic for the podcast today is going to be options for the midface.
Yes. And I think, this is a topic that is coming up in my office and my inquiries like constantly now. The midface lift is on fire in the media and in that everyone's, I think she had a midface lift. It's one of those things where I'm like, guys, I've been doing this since 1998, since before the internet. I mean, literally, this is something that I love to do. It is like my bread and butter of facial rejuvenation, and I think it's kind of become your bread and butter too.
I love the midface lift, but let's define the midface. What is the midface?
I think you've said once before on a plastic surgery podcast of this nature that the midface was the part of your face in the middle of your face.
That's it.
And I was
Nailed
like,
it.
That is the definition. It's this part of the midface is the part of the face in the middle of your face.
I think because you were trying to define it as like from the brow bone and the supraorbital rim down to the bottom of the zygomatic. And I'm like, folks, it's the middle of your face.
Yeah, that's pretty much it.
So basically,
it's your cheek. It's
the under eyes, and it's the cheeks. It's the middle of your face. And so today on our podcast, we're going to talk about the different options you have to address this area, because it doesn't always have to be the mid-face lift, although that is our go-to. There are other ways and other things that you can do.
Totally.
And it just depends on what the problem is. So typically the problem in this area happens with aging. Aging being that as we age and gravity does its worst, the cheeks and the soft tissue of the face start to fall down and become more displaced. And so you have a bone, the infraorbital rim, and it kind of holds the eye socket in place. And that's usually a very smooth step off from the under eye, that thin skin of the under eye, to your cheek. But with age, as the cheek starts to descend, it separates from that under eye anatomy. And you get this groove, this hollowing that people typically try to treat with under eye fillers and things to sort of camouflage that step off between the lower lid and the midface. And that's one of the earliest signs of aging that you're going to see in the face before you start getting jowling or need kind of a neck lift. In your mid to late 30s, this is where you're really going to start to see those first signs of facial aging.
Yeah, and that mid-facial descent also winds up making the person's face look more boxy. And this is really what gets people on the table.
Right.
When I say that to them, when they're like, I don't really know if this is what I need, but if they're there, they've already discovered that it is probably what they need if they're in my office. And, that's really the key, is that they'll look and they'll say, yeah, this seems like this is getting hollowed here, but and then I'll show them, but look, I think this has become more boxy. And they'll go, yes, that's it. I need to have that old. And when they do finger surgery where they do this, they're like, that's what I'm looking
Push their cheeks
for.
Up. Right.
Yeah.
Because a youthful face tends to be more heart-shaped. So the eyebrows and the forehead and the cheeks are a little bit wider, and then it tapers to the point of the chin. But as that mid-face starts to descend, it turns more into a square. And so even if people can't necessarily point their finger and say why they look older or why that person looks like they've aged, that's one of the main reasons. And so the mid-face, yes, in addition to kind of addressing that step off between the lower lid and the cheek, it also elevates the cheek, and by doing so, helps to recreate more of that heart-shaped face. And so I know we've talked about this before, but sometimes people don't come in and do it for aging. They do it because they want to change the shape of the face. Maybe they feel like their face is too round or too square or doesn't have enough definition in the cheeks. And so they can do it just more for an aesthetic reason, not necessarily from an aging reason.
100%. That is, and with that also is the nasojugal groove, which is not the tear trough deformity that you were referring to. It's actually a line, a ligamentous line through the middle of the face, separating some of the fat compartments of the face that you can see. It's often present in babies when they're born. You can really see that crease across their cheek.
It goes from the inside corner of the eye diagonally kind of down towards the jaw. And it's like a very diagonal.
Towards the gonial angle.
No, the gonial angle's back here.
Oh, okay.
Just like, if you're doing this, put your finger.
I only said that to make you go
you're trying to annoy me.
That was in the OR today. I said, oh, yeah, I need to fat graft over the gonial angle. And Dr. Rovelo was like, it's the jaw.
We were trying to explain to our nurse. Okay. He's like, doctor, where are you injecting? He's like, I'm injecting over the gonial angle. I'm like, Matt, he's injecting over the jaw. Mr. Smarty Pants.
I'm not a Smarty Pants. It is the structural. Okay, never mind. But back to the midface.
Nasojugal groove, yes. And so sometimes that can be very prominent in people. And this midface technique, which we'll go into the specifics later, is one option to treat that. But the midface is not the only treatment for this. So let's go through some of the other options before we talk about the surgical options.
Well, you can fat graft.
You can fat graft
it. You can do fillers.
Again, camouflaging the problem.
You're not taking care of
contour irregularities. You have lack of volume in one area versus another. So you can do filler in this area. I think I said this literally on the last podcast. I hate filler. I don't think it's the last podcast. I said this in the OR. I do not like filler under the eye. I know a lot of people do it, and it's fine. I just don't love it. I think it has its own set of problems. And it's not the best, it's really not the best solution. It's the most readily available, but you can have problems with migration. You can have problems with chronic swelling after under eye filler is placed there. You can have problems with discoloration of the skin. It sticks around for decades. It does not dissolve in this area very well at all.
It does not.
And it can have some potentially serious consequences like blindness. So
yeah, that's not good.
That's not a good one. So it's an option. I just personally don't think it's a great option. You can also just do a standard lower blepharoplasty. Let's talk about a standard lower blepharoplasty.
Well, the problem.
Well, what is a lower blepharoplasty?
This is what's getting a lot of people in my office. So a lower blepharoplasty is where you go through the eyelid either externally through an incision under the eyelashes, or as one of the surgeons doing it in San Diego, you cut right through the lid in the middle of the lid, or you go through the inside of the lid.
But you're trying to address
You're trying to get to the fat bag and the tear trough deformity.
Right. Because usually when you have that deformity, the tear trough, it's not everyone, but usually there's a component of lower eyelid herniation, which is where the fat that lives usually in the orbit due to weakening of the tissues starts to protrude. And it looks like everyone calls them the bags under the eyes. And so a way to treat that is to go in through the eyelid or close to the eyelid and literally just remove the bags or reposition them in a place that's better. And that's just a simple lower blepharoplasty.
So a couple of the patients that have come in, which is why I wanted to do this podcast, needed mid-face lifts. And this one patient paid something like, I don't know, $3,000 in consult fees or whatever to see people that could help with she had a lower lid blepharoplasty and looks worse. And, they did some fat grafting. She put some filler there and she just kept saying like, no, this isn't right. I'm not happy with it. And the problem is that everybody that she said, I saw all these people. I was like, okay. And she's like, I kept telling them I need a mid-face lift. I was like, you do need a mid-face lift. So, well, none of them would do them. And I said, well, that's because you didn't see any plastic surgeons. She's like, no, they're all plastic surgeons. I was like, well, they do plastic surgery of the eyelids, but they don't do facelifts, and you need a mid-face lift. These are ophthalmologists who are oculoplastics or oculofacial plastics or oculofacial eyelid, whatever they call themselves. They all have a different name.
They just do the eyes.
But they do eyes. Right. They don't do mid-face lifts.
Right.
She goes, no. She said, no, they're plastic surgeons. I was like, okay. I don't want to get into this discussion. I was like, plastic surgeons are, like I'm a board-certified plastic surgeon. These are board-certified ophthalmologists that do special training in eyelid plastic surgery. I said, you need somebody to do a mid-face lift. She's like, I know that. And these people said, I can't get that. I was like, you can get it. So like here I am having this conversation.
Arguing with your patient.
About the mid-face. I'm like, I know you need it. I'll do that. She said, but they said that you can't get it. I was like, but you can get it because they don't do that. They don't do a mid-face lift. They don't do it.
Right.
And
And
so
by the way,
confusion,
you don't want them to, because
well, it'd be good to be trained in doing facial aesthetic surgery of this level. I mean, a mid-facelift is not nothing.
that's what I'm saying. So oculoplastic surgeons, they're ophthalmologists. They went to medical school. They did 4 years of their ophthalmology residency, and then I think it's either a 2 or 3
They do 2 years?
2 years of an additional oculoplastic fellowship.
That's
and
right.
during that fellowship, they learn how to do some really complex reconstructive stuff, some like orbital decompressions and crazy stuff.
Right.
But they also really focus
Treat
also
ectropions, things that are really complicated.
things that are really complicated with the lids. They obviously know how to do standard blepharoplasties,
Totally.
cosmetic blepharoplasties.
I think an ophthalmologist
But
does
like
that.
really, they just think about that orbital rim, those bones that go around the eye, and that's sort of their purview. They don't really do anything for the brows. They don't do anything for the cheeks.
Some
'cause
do.
That's outside of
some
the
will,
eye.
but some will do
Some
brow
do.
lifts
Some will do
because,
brow lifts.
as I always argue, you can't really do upper lid blepharoplasty without a brow lift.
But not
I know.
not that many.
Not
of
many
them.
do them. I understand
Yeah.
that. They
So
usually
that's
bring in a
just-
plastic surgeon to do the brow while they do it, which is a smart thing to do. So her problem was that she was getting information that was based on the wrong set of operations. It's not that she didn't need a mid-face lift. She did, but finding somebody that does a mid-face, even plastic surgeons don't really love doing mid-face lifts. I don't know a ton that are like all gung-ho about the endo mid-face. They'll typically say, oh, I get the mid-face through the high
face,
smash,
yeah.
right? That's because you can, for sure. I mean, there's no reason you can't address the mid-face that way. To me, it looks different, and it's fine. It's not my favorite, but you can get the mid-face lift through the facial, doing some sort of facelift incision, carrying it up either into the hair or in front of the hair, where you do the pretrichal incision. You can totally get the mid-face that way.
Right, but what we're talking about is the endoscopic facelift.
Correct.
And those are small incisions, one on each side, up in the temporal area, and then through a sort of a deep dissection, we go from the temporal forehead, from the side of the head, down to the cheek, identify and release all of the structures that have started to descend, and then literally just pull them up and suture them back into position. But it's all done through these small incisions in the hairline, as opposed to a facelift, which kind of puts incisions
On
around
the skin,
ears
and around the ears.
Around the skin.
Yeah, these incisions are usually three inches at the most, and probably more like 2 inches.
more like 2.
Today it was like,
Yeah,
those
they're-
might have been
they're
an inch and a half today.
Yeah.
Because we didn't have a big brow component on that one. So,
Right. So that's the other thing too that we didn't talk about with the brow. It's not uncommon when we're talking about doing a mid-face to snag the brow at the same
course.
time.
Yeah.
Because usually if you're at the age where you're seeing changes of the mid-face, aging changes, you're probably also seeing changes of the brow and plus minus the upper eyelid. And so a lot of times you can add on a brow lift at the same time as the mid-face because you do it through those same incisions if you're doing it endoscopically like we were talking about. Because it's right there. It's the same incision. You're in the exact same area. You can snag the corner of the brow and lift it as well.
and you can do the full medial brow if you need to, but that's pretty rare. The medial brow I only go after if it's actually
inner-
gotten
the inner
into,
part.
the part towards the nose. I don't typically lift that unless it's in the orbital rim.
Right,
And
like
I-
really low.
Yeah, I like to really contour that lateral, and you can really contour it nice and get a good arch, and then you bring the mid-face with it, and
Yeah, it's so nice.
it's so
It just
nice. It's such a
opens
great
up the
operation.
face. It really rejuvenates it. But it's not. I mean, you can make an extreme version of it. You can really, really lift the cheeks and really lift the brows and give you that kind of mantis look that we talk about sometimes if that's what the patient is looking for. You can do that with this procedure.
I get a few
But
that want the mantis.
in general, people who just want, sort of a rejuvenation procedure, you can do this and people won't think they've had anything done, or even if they see them 2 weeks later or 3 weeks later, they know they look different, a little better, but like they would not be able to pinpoint like what you had done. They just think you look, more rejuvenated. So it's a very natural, subtle look, rejuvenation.
Totally. It was like when you had yours done, and that nurse looked at you one day, and I'll tell the story because I was operating, and Dr. Rovelo poked her head into the OR and was like, "All right, I'll see you all later," and kind of waved and went out. And our nurse, who was there intermittently, she was kind of like there every 2 months or something, she said, "Oh, Dr. Rovelo is very beautiful. She looks like a movie star." And I said, "Yeah, she looks great." And she goes, "Did she always look that good?" And I kind of like, something happened. And I was like, well, you could talk to her about it, but, there was a little the mid-face lift, you were probably 4 months out from that operation. And it made things look, it just kind of opened your face.
Right. I needed it.
Yeah. Well, I mean, need is a strong word.
Need is a very strong word. But like I was seeing the signs of aging and I was seeing what was happening and I was like, okay, I need that.
Yeah. And it worked very well. And it was very noticeable because this nurse who has a great eye for aesthetics, noticed it. She was just like, wait a second, that's, because you always look great, but then it was a different level of, that she could really perceive, but had no idea what it was.
Why.
Had no clue. Just kind of like, what happened? Is something like, why does she look like a movie star? And it was, it was very noticeable because she's an aesthetics nurse. She knows that stuff. Like she can see, oh, something's different. What happened?
Yeah.
And that's kind of what you're going for with that. You can make it look mantis-like if you want to. You can really
make it extreme. And if that's what you want, fantastic.
I had a patient recently that wanted that. She was like 34 years old. She's like, look, do your worst. She's like, I want this to look crazy. I was like, I'm not making you look crazy. She goes,
please.
Just your version of crazy then. I was like, all right. And I pulled to the moon and she was so happy. She loved it. It was like, but that's what they want. You got to give the people what they want.
Right.
That's
can you reverse that?
It's hard.
Like if 5 years she's like, okay, I'm over this look.
Well, kind of. It's hard. You have to really like. There's a way to lower that, but it's not easy. And especially after it's kind of scarred. Like people say, oh, when do I have to repeat the brow lift? Like I'm waiting for the one that I need to repeat. I mean, they're pretty rare. Some of them need a little help with the skin because when you do the subperiosteal, 10, 15 years, you might see that you need to kind of do a little bit of a skin brow, where you take a little more skin out and elevate it a bit. But I haven't had to do a whole lot of subperiosteal redos. They've been like kind of minorish. And I had a patient recently come 18 years after I did her facelift, and we refreshed the brow too, just because we were there. We're like, yeah, let's just get a little bit more, and it looks so good. But it was impressive how well it held up.
Right.
So that's 18 years. Starting when she was like I think 43, so she's now 61, and refreshing the operation.
Well, because part of the thing too with the midface, the endoscopic way that you're referencing, is that there are ligaments, or there are structures that go from the bone to the skin in that tear trough area. And so that's what makes that step off so obvious, because there's this ligament that's literally tethering the skin in that area down to the bone. And when you release it to do the lift, it's done. It's not going to reform. So you're never going to have that step off again, even if the skin starts to fall with gravity.
You'll never have it again.
You'll never have that step off because those ligaments have been obliterated. So, yeah.
Easy for you to say. Yeah,
I know, right?
They've been obliterated.
Obliterated.
I kind of like that word, actually. I'm going to obliterate these ligaments. How about that?
Start saying it. And
I'm going to say it, and then people will think, wait, is that actually the word? It was like when Gabby said autologous, and then Osita came to the journal club and said, an autologous rib graft. I was like, man, Gabby really got in your head.
Well, you know what? So 2 weeks ago at my other office in Whittier, I had some of the office staff ask me, they said, Doctor, is it autologous reconstruction or autologous reconstruction? And I was like, where is Dr. Calvert when I need him?
Oh my God. I would have lost it. That would have been great. It was so funny because, it sounds like a dinosaur, autologous Rex.
I think I said that. They were like, huh? No.
Humor's lost on that. Anyway. Well, so for the mid-face lift, though, I think the real key to getting a great mid-face lift is finding somebody who loves it. Who has two thumbs.
Who in this room has two thumbs?
And loves mid-face lifts. Me. This guy. Yeah, it's really a great operation. There are people that really do it, but you have to find people that are very into it and get great results with it, because it's a big undertaking. I remember around when I got to Newport Beach, and I was doing this, in my residency at Pittsburgh. I used to do these like in my resident clinic, and and Dennis Hurwitz was all on board with me, and Ken Shestak, and they would come in the room while I was doing them, and I was like, this is what I'm trying to do. Oh, that looks great. And I got out to Newport Beach, and Harvey Heinrichs and Malcolm Paul and Bruce Dubin and all these guys just love the mid-face lift. They did it like it was in this one surgery center in Newport Beach. Everyone did it because Harvey Heinrichs was and Malcolm Paul were sort of the pioneers of doing that stuff, and also Nicanor Issei. And it kind of is a Newport Beach-based, maneuver. And in fact, the first endoscopic face course that I went to, endoscopic plastic surgery course I went to, was in 1993 at Emory University. I was a medical student from Cornell visiting with, I remember I was visiting Monty Eves and Mark Codner and Greg Mackay and all these guys in Fodna High. And there was Roland Daniel, talking about doing brow lifts and mid-face lifts with an endoscope. And Nick and Orise and all these guys from the same surgery center just dove into this thing and got it going. And that's when I sort of picked up on doing it. So that's some years ago now. Is that 32 years ago? So that's been some time. And this operation is now kind of getting the spotlight, which shows you that's a lot of time. But Harvey Heinrichs would do 3 of these a week, and they were booked. He'd do them with the lower facelift, doing a high smash flap, upper endo. And his patients look great. There was a lot of Newport Beach ladies. Nobody knew, what the facelift was that they had, but clearly they had one. And they didn't look facelifted, because that's what I loved about the endo blended with the lower. It just, it looks so good.
Right.
That's what Chachi Ko does the ponytail lift.
Yeah.
That's what it is. It's an endoscopic upper face without doing the incision in the front of the ear. Yeah. And he does everything in the back, like where the ponytail is. But, for me, he does other things here to make this work for him. I tend to make the incision. That's all. And I think that's what will be our discussion tonight at LASPS. And he does some more aggressive things through the face with the endoscope that are very cool.
Yeah.
But everybody's got their way, and that's really the key. There's a lot of ways to get a great look. You just got to go by the before and afters, because the technique really changes the result in this situation.
In this situation, it does. Sometimes when we talk about facelifts and smash flaps versus deep plane, a lot of it's you'll get the same result as long as the surgeon,
you'll get there.
Is competent. But I think in this one, it's definitely the technique matters for the result. Whether you're doing a mid-face, endoscopic mid-face, whether you're doing a lower blepharoplasty with fat grafting, the results are going to be a little bit different.
Yeah, I mean, I liked our case today. We got that major league release and got it elevated, and she was, very specific, don't want a whole lot of brow lifting, so we really we could custom tailor this technique.
Yeah, big time.
So powerfully, and that's why I love it. It's just, it really gives you the controls on getting the look the patient wants. There's not a lot of guesswork.
Yep, I agree.
Well, in that case, this is the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.